Good evening once again, and welcome to tonight's webinar. As you will already be aware, this is Medically Speaking. We're joined by our guests again to discuss men's health. But before we start, and before I reintroduce my guests, let us open in the word of prayer. Father God Almighty, we just want to thank you. We thank you for the opportunity to come and share on this virtual platform, my God, information that we pray, mighty God, will impact our communities. We pray for these, your speakers, the experts that we have here today, my God, that you will bless them, my Father, and that you will provide them with wisdom and guidance as they deliver a clear message, Father, that will be useful to those who are listening. We thank you, my God, for our leaders, my Father, who have come up with the vision. Continue to bless them, mighty God, including the IT team that supports us. We thank you in advance and we give you all honor and glory. In Jesus' name we pray. Amen.
Amen.
So thank you so much. And for those people who are joining us for the first time, and for those who were here the last time when we discussed this topic, I'm joined once again by Dr. Kabo Ijane, our urologist, and we are also joined by Dr. Ndandla Mdalose, a GBC doctor, who is also a GP in Soweto. So I think we need to remind people, it's been a few weeks that we met, and we had a very good discussion around men's health. I think the pieces that we touched on were around, the healthcare seeking behavior of men. We're worried that our fathers, our brothers, our uncles, may not be seeking healthcare as they should. They usually are scared for whatever the reasons, or they avoid having health discussions at home. So we did have those discussions. We also then touched on specific aspects around prostate health. We spoke about what the prostate is, and I'd like Dr. Ijane to just refresh our memories because, we forget as humans. So just to remind us what the prostate is and why it's important. And I think today we're going to also address some of the questions that were raised before. But what we'll do, instead of going through the questions one by one, we'll just address them in terms of themes, still focused on men's health, specifically focused on prostate health, and also other aspects of just the general well-being of a male person. So Dr. Ijane, I'm just going to welcome you again and say thank you so much for always willing to come and share with us. So today we are just continuing our discussion, and really we appreciate you taking the time to come and share. So just maybe a quick recap so that we can get into today's business, but so that people remember what we were talking about, and then we can move into today's. And I think for those people who are joining, please, today we want to really address your questions. If you can just post your questions so that we can discuss your questions and make sure that you leave here feeling empowered with information and knowledge. Thank you so much. Over to you then, Dr. Ijane.
Good evening, Aka, my colleague, and thank you very much for inviting me again. Greetings to all the audience that we have. Last time when we met, there were very pertinent issues that we went through. However, just to recap, so we are all on the same plane because today we're focusing largely on prostate. A prostate gland is part and parcel of every man. It's a small little gland that is sitting right at the mouth of the bladder and the root of the penis. So inside our hip bone, what we call the pelvis. So literally, if you were to take the space between the anus and the scrotum of a man, that area is called the perineum. If you just press halfway there directly into the body, that's going to kind of like lead and poke towards where the edge of the prostate is sitting. So behind it is the rectum, in front is the pelvic bone, through it is the urine pipe, just ahead of it is the penis, and then behind, obviously, it is the bladder. It is lodged right there. Every man is born with it. I did last time address the fact that from puberty, when the voice break, the Adam's apple develop, the prostate start growing, it continues to grow throughout our life. So when you hit 80, it still be going from your puberty up until 80, which most of the time it will be 11 to 13. So for a cool 67 years of growing. And that growth does not necessarily mean perpetual size increase. It could mean that what we call the supportive structure of this thing called the prostate, we call it stroma. It's changing in its nature, in its texture, it's increasing in its volume, the amount, the number of muscle cells that we have within that prostate gland are increasing, or the actual gland size is also increasing. It serves a very simple purpose. It helps us with keeping urine longer in the bladder for men. Unfortunately, can block it later in life, but it's also very useful for ejaculation function for a man. So sperm will be coming from the testicles, and then it will mix with something called semen. Semen is little glands which are like extension of ears of a donkey or a horse, and then the head of the donkey or the horse being the prostate gland. And the prostate add a chemical into this semen, which is called prostate specific antigen, PSA, which we're going to talk a lot about tonight. So that PSA has got a what we call a physiological job, the function of day-to-day functioning of our human body. It supports that. It liquefies sperms and semen so that we don't ejaculate pellets and we emit something that look like a condensed milk or what we call a coagulum. So that's a prostate in a nutshell.
Okay, so and I think just to remind people who are joining us today that as we said last time, we call a spade a spade. So please just feel comfortable. It's actually quite good that this is a virtual platform, so we can just openly speak about this without people cringing a little bit. So we gotta call the organs the way they are. So maybe just before we get into the main discussion of the day, Dr. Mdlalose, maybe as part of recapping from last session, we spoke about some of the reasons why our fathers, our brothers, our uncles do not seek healthcare. I mean, maybe just to highlight a few of those, and also maybe the message that you would want to give as we start this talk, to say, why is it important for us to have this conversation?
Thank you, Dr. Nodotando. Good afternoon to you, to Dr. Injane, and the audience out there. Today, I thought maybe we should make this. Last time our topic was more academic, so I thought this week we must just make it practical, to make it easy, accessible to the audience. But to get to your question, we said last week, just to recap, we said Abu Baba, they are afraid of consulting doctors. They like to seek treatment elsewhere besides the formal health structures. Two, we said communication. Abu Baba, they don't communicate much about the problems that they face as compared to women. Women, they even become champions of their illnesses. You'll find them advocating for breast cancer awareness days, but that's rarely in the male counterparts. So communication, even within the family, mainly because when we were raised up, we're raised to be these macho beings, Batu Baba Agakali. When you show your emotions, they say you are a weaker man. So most of the males out there would be afraid to consult or reluctant to consult because of the stigma attached to a person who comes back with a diagnosis. So when you come back, they say that you are no longer the macho man because you have this diagnosis that was made. And then the other thing we said, the barrier to people consulting in our society will be the availability of health facilities, especially in rural areas, people where they have to walk long distances to access healthcare. The other thing was time, the availability. We spend most time at work, so making time for consulting as Abu Baba being the providers of the family. They prioritize providing or taking care of the spouse and the children and forget themselves in the process and then put it at the back, the issue of consulting doctors and the primary health care.
Yeah. No, thank you so much. No, thank you so much. So I'm taking it that Abu Baba have taken the time this early evening, late afternoon to come and hear what you and Dr. Ijani are going to be sharing today, and that they are really going to use this information to actually assist with bettering their lives. So, Dr. Ijani, now we're going to get into just the prostate again, because it's an important organ in the when we discuss men's health. So last week we did speak about prostate cancer, but I'd like us today to just start, because you said this prostate is there when you are born. It grows with you as you grow older, and you spoke about the benefits of having it. But as you grow older, there are certain things then that become problematic for Abu Baba. And I think with Dr. Ntandla uzosixelela ukuthi when they come to him, what do they usually present with? Maybe let's start with Dr. Mdlalose to tell us, when they come to you, Dr. Mdlalose, what do they complain about? Because then Dr. Ijane is going to unpack it to say this is the reason why they usually present like that. Maybe let's start with you.
Yeah.
Okay, thank you, doctor. Usually when they come, we are the first line. So first line in this army, when a person experiences challenges with their body functions, the first person they come to will be your GP in most cases, those who can afford, and then those who don't afford, they go to local clinics, because it's the very same care that they get there. Normally when they come with, remember when Dr. Ijani described the position of the prostate, he said it wraps around the urethra. So the symptoms that we will be experiencing, or the patient will be experiencing, will be related to the obstruction of the urethra. So one, it will be the agency to pass urine. So when they come to us, they will say, doctor, you know, I pass urine, and then immediately after that, I feel that there's a need for me to go back and pass urine. Then the other symptoms that they come presenting with is the frequency of passing urine. They will pass urine, and then when they get back to the car or the office, there's a need to go back and pass urine. Then others will come to me and say, doctor, you know, after passing urine, there's this feeling I have that there's still something that is behind. It's like I didn't empty the bladder. That will be another symptoms. Others will come saying, my quality of sleep has been affected lately. I wake up too often to go and pass urine. We call that nocturia, where you wake up, go to pass urine at night. And then others will say, doctor, you know, I have experienced this thing that when I pass urine, there are droplets that come out. So dribbling, we call that dribbling. They pass urine, but when they have finished, after zipping the trouser, then they find that they are wet when they look down there, because of the leaking of urine. And then others will say, doctor, I've noticed that when I ejaculate this time, there's this burning sensation. There's pain when I ejaculate. Others will come in saying that, doctor, I see blood in my semen when after ejaculating. Yeah, in a nutshell, those are the symptoms that they present with at the primary health care.
Thank you so much. That's very useful. Then Dr. Ijani is gonna like unpack for us to say, why do they come presenting the way they are presenting?
Okay. Thank you, colleagues. Thanks, Dr. Mdlalus. I want to add on what Dr. Mdlalus said before we carry on further. Family practitioners, general practitioners, local doctors and clinics, especially the family practitioners, the general practitioners, they're not only the first line, they are like conductors of the choir. They know who goes to the orthopedic surgeon, who goes to the neurologist, who comes to the urologist, who need a nephrologist and not a urologist. That's very, very important. And they know your file. They live with you. They have seen a lot of things changing in your life. The specialist is just a quick snippet on what's happening with your life, and it makes our life a lot easier if there is a brief summary of the cascade of events from your general doctor, your common doctor who's been following you throughout. The recommendation I like making is that, please, we know that the doctor is not always there to see you when you want them to, but have a go-to doctor. That when you realize that I've got these nagging symptoms, you follow up with that doctor. So we don't keep reinventing Rome. You go to see Dr. Mdlalose, you go to see the Dr. Nolutando, you go to see, and every one of them keep giving you what we call first line of treatment. And you don't even realize, because the other one likes one called Uromax, the other one likes one called Alpha-Win, the other one likes one called Silodosin. It's like I'm giving you Panado, Painamol, Paracetamol. And you say, I've drank so many medications, I'm not getting well. You've just been using the same thing. If you went back to the doctor, they would have known that, okay, I've tried this. Maybe it's high time I call a specialist for further advice. And then we can even guide them long before you come to us. Try 1, 2, 3, do this test. Remember what I told you last time? When you walk through my door, usually I want to ask you, is there something to cut out of you? Because I'm a surgeon. I don't like being there and conducting and sending to others. So it's very critical and it's very important that we make that part and parcel of our general well-being and health. So by the time we go to the specialist, you don't arrive there holding your waistline and saying, doctor, my kidneys are giving me problems. And I'm like, Okay, so back to prostate and prostate diseases. We had a discussion with Dr. Nolu and say, okay, we're going to try to divide this into non-cancerous disease of the prostate, causes of treatment, and then we will deal with prostate cancer again, treatment, and what you can expect out of that. So the first part of this talk will be based on, if the prostate is sick, it does not necessarily mean cancer. Like we've said before, and the symptoms that Dr. Mdlalose have added to you, you're going to realize that the biggest problems are either sexual or they are with urine and urine emptying. So the sexuality part of it is not as big, but it's important after treatment. The two very important pertinent things that he mentioned is discomfort, pain, and blood after ejaculation. That's one part. So problems around ejaculation could be related to the prostate. Of course, there are other things that could affect them. That's why medicine is so broad. Number two, it could have to do with how long you last. So you used to think you are a man, and now you are a 10-meter. So we have to be, yes, to be very careful that we have symptoms that you're experiencing. I'm getting a note that I'm reconnecting, so that's why I'm stopping a bit.
Yeah, I think your connection is a bit. Yes, we can. We can, but I think your connection is not great. Okay. Okay. Now now
Am
I
I
think you're
back
fine.
now? Yeah. Hello, Doc.
Yes, you
Yes.
are. Thank you so much. Thank you.
I realized there was a bit of an interruption. So yes. So now the sexuality, and if you start all of a sudden having premature ejaculation, which was never there, prostate could be one of them. Of course, there are other things related to that: sugar diabetes, stresses, excessive ethanol intake, some other infections. So all those things are important, and therefore it does not always mean prostate. When it's coming to the urinary symptoms, we group them into: can you store the urine? Meaning,
Okay,
are you
so
able?
let's go back. Let's go back, Doc. So I want
Okay, no, not a problem. Yes.
I want us to package this well. So you spoke, when you say ethanol, I'm like thinking, I'm sure other people are like, what is he talking about? Alcohol.
Thank you.
So
Please feel free to keep adding those words when
yes,
I'm being
yes.
too scientific.
Yes, we'll try. So I think it's important. So you're saying this is a person who has been having a good sexual life, and suddenly they realize it's either there's pain, there's blood, or they are no longer. You said they don't. I think you got
They
cut
are
when
no
you were
longer a
saying.
mile man. They are a 10-meter man.
So now it's quicker. Yes.
It's quicker. They ejaculate quickly.
So you said premature ejaculation. So, and those things are quite stressful. And I think it's important to say all of those things, like you said, it doesn't necessarily mean that there's something wrong with the prostate. There could be other things. That's what you said. You said there could be other diseases that a person is living with that could be resulting in that. And I think it's important. You spoke about stress. You spoke about underlying diabetes and maybe hypertension and other conditions that could be giving people those problems. I think it's important to just capture that and then before we move on. And I think with all of those presentations, it's important then that they come to Dr. Mdlalose or any other doctor and say, doctor, this is what I'm experiencing, so that the doctor can look at the history, look at medications that they're taking, and then understand, is there a problem here or it is because of something else. So that's the first part. Okay, now let's
Very
move.
well, very well summarized, Dr. Nolu. Thank you very much.
Yes.
Yeah.
Okay.
So
Now,
now, obviously, if you are diabetic, you don't come to me as the first point of contact. That's why it's
yes.
important to start with your family practitioner, with your family doctor.
Yes.
Let's move to prostate diseases that are not cancerous and are not ejaculation. The one of urination.
Yes.
Now, the bladder holds urine, and most of us, we should be able to hold 350, 400, and when you push it up to half a liter of urine, meaning you should be able to even delay the need to go to the toilet. And when you do go to the toilet, you must be able to stand there or sit there and empty the bladder very well in a shorter period of time without the symptoms that Dr. Mdlalose alluded to earlier. So we break prostate interference in the urine into storage, meaning you are not able to store. Remember, he told you nocturia, you wake up a lot. He told you frequency, meaning you have the urge to go to the toilet now. If you gotta go, you gotta go. So most of the time when we drive and we see men standing by the roadside and peeing, we don't know it is behavioral or because the prostate and the bladder just couldn't take it anymore. They had to stop. So we don't know, but it could be one of those. You have the urgency. By the time you have now unzipped the pants, the urine is already dribbling out and coming out long before you can point where you need to point. So those will fall under, you do have the problem with storage, so you are not a good storer. You have to rush and empty quickly. And the other group of symptoms are you are not able to empty as well as you should. So yes, you could store, you go to the blue. When you arrive, you stand there and it's like, what am I here for? The urine is still coming, but it's still a few meters away. So it's called hesitancy. It's like, okay, I have to push. Almost the same feeling like most men would experience, or all men would experience after, if you've just ejaculated and you go to the toilet to try to pass urine. It's like there is a lock. You need to wait for that lock to release. So if that starts happening and this is not even linked to ejaculation, that's what we'll call hesitancy. When that urine does come, it's now a weak stream. So you can tell when a teenager is in the bathroom next door to you, you hear brrr, pa, and then it stops. It's like they're flushing something out. And with an elderly gentleman, you hear tzr, and then it stopped, and then tutur, then it stopped, and tur. So the stream is interrupted, it's weak, you have to push a lot and strain, and then afterwards it's dribbling because obviously there was not enough pressure generated to push everything out. And that can progress to complete blockage of urine, where in some instances you totally are not able to empty, and therefore you are blocked and you need to be rushed to the healthcare facility as an emergency. And then there is insidious things that are away from our eyes, which we call them damage to the other organs. So now, because you're not emptying enough, the risk of infection into the bladder is common. So you can end up with repeated bladder infections. Remember, guys, that the fact that the urine is burning or hurting a bit does not necessarily equal an infection. So just caution that when we say repeat, it doesn't mean just
I think your
yesterday.
connection
We
is
usually have
starting
to
again, Doctor. Your connection again is giving you a bit of a problem. Okay,
Hello.
better
Yes.
again. Okay.
Sorry,
Yes, we
sorry
can hear
about
you.
that. I don't know what's happening today. Maybe they're downloading something big. The kids, they're all home.
We pray against whatever is happening there. We pray
Thank you very much.
for clarity. Thank you. Thank you.
So the damages that can happen is because those infections, you can end up with what we call bladder stones. So the crystals in the bladder that are supposed to be washed out, they form little salt crystals, which is what bladder stones are. And then because of infection, they can grow big. Sometimes the biggest one I've removed out of the bladder was 7 centimeters. That's a very big stone. And then you can end up with kidney failure just because your bladder outlet was blocked. And that's why now it becomes very important to see if we are giving you treatment, we're following you through, is it working or is it not working? So in a nutshell, that's what happens to the diseases of the prostate, which are not necessarily cancerous. And why do they happen? Firstly, just because we've got a prostate. Number two, we are growing older. Age, it's important. Hormones, chemicals, and of course, genetics, who you born to. The size of the prostate is almost like the height of an individual. It's largely that. And then there is a cascade of all complex theories why we get this, which Dr. Mdalusa cautioned that we shouldn't get too technical, and I will resist from going into the pathophysiologies and just say those are the symptoms we should look after. And when you see those, that means that you need to get checked, and then we can do advanced tests from prostate examination, urine testing, trial of medical therapy, and then eventually we may need to do advanced testing, ultrasound, including CT scans, computer tomography scans if they are necessary, which are more high definition x-rays. And then of course, you may in some instances require to have blood tests for kidneys. If we find that your kidneys are holding lots of water, we call it hydronephrosis, then you need to have tests to see that your kidneys are working well. And then we sit with you and discuss options for treatment.
Perfect. Okay. Let's recap then. So you're saying, so you explained that, I think Dr. Mdalusa already explained as well in terms of the symptoms. And you said because you're not emptying enough, so this urine that's sitting here, it can collect bugs, which is what we call infections. So these bugs, when they are there, then you present with symptoms related now to almost like this dirty urine, if I can put it like that, because now the infection makes it dirty urine, when in actual fact, urine is usually clean and it goes out because it's just part of how the body cleanses itself. Now it's sitting there because it's not getting out. It collects all the germs and then it becomes problematic, and then you can experience that. And then you spoke about the fact that because it's also sitting, it can form these stones that can also present with problems. And then you said over and above the fact that it can be a problem in the bladder, you spoke about the kidneys themselves, that the kidneys can also have problems, and people will present with some issues. I mean, there's a person here who speaks about back pain, and they say there should be some organ that is important around the back, and I think you can maybe explain where the kidneys sit, Dr. Ijane, because I think it's part of this whole system that people are worried about.
Okay.
Where are the kidneys?
So the kidneys are well protected to start with. I'll explain where they are now. But the first point of contact, what is very important with your back, is your bones and muscles. So we look there first as the initial port of entry for backache. So if you are standing up just below your ribs, the lowest part of your ribs, and then almost maybe on the sideways of the center of your back, where your spinal cord and your backbones are, just a little bit to the lateral side of that, below the ribs. That's where the kidneys are. And the left one is slightly higher because the spleen is a smaller organ in the body. So the kidney is hiding a little bit higher there. So it could be even above the ribs. On the right, the liver is a bigger organ. It's pushing it a little bit lower. So they're not necessarily at the same level. Yeah. And then, of course, there is big bowel, colon, muscles, and all others that could cause back. Back is not necessarily around, and then it's kidneys lying down there.
Perfect. I think that's very important, because every time people have a little bit of back pain, they'll think, oh, my kidneys. So it's important to know that there are many other structures that are there that, Dr. Mdlalose, when they come to him, he will examine first and say, maybe it's muscle, maybe it's something else, before they can say, now let's send you to somebody who's going to check your kidneys. So I do want to just incorporate most of what people are talking about on the chat. But I think before we get to that, there are certain things that people would want to know. I think you spoke about why some of these things happen. You said it's the normal process of aging. But when we say aging, at what age do people start presenting with some of these symptoms? Doctor, maybe I'll ask the to say from your practice, at what age? At what age?
Let Dr. Nhlanhla go. Let Dr. Nhlanhla go. Then
okay. Let me come in here. We said today is practical. Just before we get to that, there's something I wanted to mention, that these symptoms we are mentioning, they are not specific to the prostate. There's other causes of these symptoms that we are mentioning, like your nocturia, your frequency that was mentioned earlier on. So when you come to me, your GP, your general practitioner, what I usually do, I try to screen for all the causes of the symptoms that you are presenting with. So an individual is a holistic individual. Is not separated into the heart, the prostate, the eyes. So when they present, we try and find the problem. So the problem could be somewhere else. So there are other diseases that will cause these symptoms that we are talking about. And number two, besides the diseases, lifestyle, the way you live your life can lead to these symptoms. For instance, if we take nocturia, a person who will take a glass of water just before going to bed, that person will inevitably wake up later during the sleep because of the time they took fluids into their system. Number two, your alcohol. We call these diuretics. Your alcohol consumption will lead you to passing more urine, especially as well at night. And then there are other medications that we prescribe at doctors that will also cause you to pass frequent urine or having nocturia. So it's just a holistic. So when you come to me, what I usually do, I take a detailed history to try and eliminate these other causes of these symptoms that we have discussed. Then when we have zoned into the prostate now, then we concentrate and focus on the prostate. To get to your question earlier on, you said when is aging? It's a difficult one, but what we say normally is around the age of 45 to 50, when you start experiencing these symptoms, you should definitely consult your doctor. Because last time we said prostate cancer is common in Black communities. So once you get to the age of 40 and then you realize that there's a shift in the way or habit, the way you do things, just come to us and then we will direct you on where to go, what to do.
Wow, I actually like that because it's a holistic view. When a patient comes to you, you don't just say the problem is the prostate, which is why, you are a generalist, because you have to think about all the possible reasons why a person could be presenting the way they are. And by the time then you refer to Dr. Ejane, is because you have actually then identified where the problem is. So Dr. Ejane, when do they come to you? What age usually do you start seeing, our dads, our spouses, our brothers and uncles coming through to you?
Well, with blood in the semen, usually that's one thing that get men coming to the practice very quick. So for that one, most of the time, they could, maybe the first time when it happens, like Dr. Mdalose alluded earlier, they'll have a bit of a shock, they may be in denial, and then the second time and they'll be at your door. So usually all across ages, even in the 20s, the 30s. Premature ejaculation also commonly from 35 to 40. I think when men are still younger, they've got all other things that are clouding what they are doing, and they don't pay attention to this. And then when they approach that age, they start realizing, this is a little bit of a problem. And then when they start getting the symptoms of urinary block, mostly it's after the age of 40. It's very insidious. So therefore, it might have been going for a while before one eventually accept that there's a problem. So that's always the challenge. So part and parcel of the recommendation we give broadly is that, like we mentioned before, from the ages of 40, get screened. That will include even direct questioning by your doctor on some of the symptoms that you might be just overlooking a little bit. And that could be very, very important. A simple thing like you've gained weight and now you're snoring and you've got nocturia might be the reason that is bringing you to the doctor. But in actual fact, there are all other issues that are associated with why you've gained weight to start with.
Yeah.
So therefore, from the age of 40 is very important to go. And then once we've looked and then done the test and we say, okay, this is now prostate, the options could be we give you tablets or we do nothing sometimes because it's so minor, but we alert you that you need to be followed up. To then we give you medications. There are different sorts of medications in the market that you can get to help you with passing the urine. If you've got some of the complications that we already spoken about, you are blocked completely, you really cannot pee, or we realize that your bladder is taking some damage and the kidneys are being affected, recommend some sort of surgical intervention. And surgical intervention is broad. It does not mean we are going to cut you when we say surgical intervention. This usually will be telescopic. We may put a tube just to empty. We may then have to perform surgery. We may do some scraping. We could use laser. We could use hot wires, or we could do open surgery now, where we have to remove the prostate in its own entirety, plucking it outside from within the capsule. So when it's non-cancer, think of the prostate, it looked like a nectarine or an orange. And then when you open the orange and you remove the inside and you leave the skin behind. So that will be the type of procedure or operation that is done for a non-cancerous one. And therefore, that's why a lot of the complications that you will get when it's a cancerous operation are not the same with this one. And with medication and the surgery, you're more likely going to end up without ejaculation. So that's very important. Remember what we said when we started. Semen, sperms, they pass in the middle of the prostate. Now, we either giving you medication which opens up the mouth of the bladder, and the pressure dynamics come to play. So when we ejaculate, sperms now mix up with urine and come later. Usually for people taking prostate medication, they could experience that. If you stop the medication at a later stage, you will be able to regain the ejaculatory function again. The orgasm still remains, guys. So the orgasm and ejaculation are not two of the same thing. They are totally different. You will feel that I've popped, but you're not going to see the bullet that you've popped. And that's important. If we now do surgical intervention, the bullet is permanently not coming out. So you are just shooting a Russian roulette without any loaded bullet. So there will not be ejaculation. There will what we call orgasm that will stay with you as long as you are sexually active. Some procedures are deemed to be ejaculation sparing. Nothing is 100%. The best result you'll get about maybe 40% of the time where you are successful with that. Unfortunately, with ejaculation sparing, we have to do very limited work, so you might need reoperation within a short period of time. Those are pros and cons that you'll discuss with your specialist.
Okay, so let's recap. That's a mouthful, and I'm worried now we've got 18 minutes, so I'm gonna try and focus us. So you're saying, Dr. Ejane, when there is no cancer, you have these symptoms, the prostate has grown, it's big, and it's giving you problems. We can give you medication to make the prostate smaller so that you are able to pass the urine. Or if it is too big, we can scrape it, but the main aim is to just make it smaller. Well, to shrink it, if I can put it that way, so that you enable the urine to pass. And you're saying as you do that, there are certain things that can happen that may not be, some men may not like what the side effects are of the treatment, in that suddenly you are not seeing your ejaculation, but you can still have a healthy sexual life. Can we just put it out that way? You can still have your erection, you can still have your orgasm, so which is where, okay, and then, but you just don't see anything at the end of it. But it doesn't mean that there's a problem. It's just part of the treatment. If you stop the treatment, you know, this process can be reversed. But when you have operated, the process may not be reversed.
It's permanent, correct.
It's permanent. Okay, so that is that. But in terms of the sexual life, a person can still have a healthy sexual life. The reason why I'm saying this is because there are people on the chat who are speaking about themselves having now had a cancer diagnosis, and the prostate was removed as part of the cancer diagnosis, and now they can't have an erection at all, so they've got erectile dysfunction. Maybe let's touch on that, because it's a major complication that really psychologically affects our men. So maybe, I don't know, I'll start with you, Dr. Ejane, and then maybe also bring in Dr. Mdlalose, because I'm sure, Dr. Mdlalose, they also come to you with those side effects. What can be done? I think the most important thing, a person who's on this call saying, I am struggling, what can be done, Dr. Ejane?
Yes, our audience to our first talk, I'm sure some of it you could avail it to them. We discussed in great length causes of prostate cancer, different testing, screening, and the diagnosis of that. So let's spend this moment saying that what do we do now that you've got cancer? Because that's where really it starts. So like Dr. Mdalose mentioned earlier, the human being is a complete unit. There's not just prostate. So we don't look at just the cancer separate from general health, and you shouldn't, as men, also look at erectile function separate from your general health. If you have chronic diseases, blood pressure problems, cholesterol, sugar, diabetes, stress, whatever it could be that is bringing it, problems with substances abuse, relationship problems, all those things can affect the erections of the erection functions of a man. And also, of course, unfortunately, as we age, you will not be functioning like a teenager who's just waking up 4 or 5 times with a lot of erections. They will be gone. The morning erection is gone. And now, as you grow older, I'm stressing you by telling you you've got cancer. Now I've added stress. And then the next thing I'm going to tell you that we are going to treat you. And the treatment, this is very important. And the reason I'm saying that is because we catch cancer early if it's there. When we've got that, we can avail to you.
Yes, I think there's also again a bit of you're blurry as well now. Yeah, maybe move a little bit. Okay, I think you're back. Yes, you are back now.
Okay. All right. I wanted to say the very important thing also here to do is to just make sure that your general health is good, but equally we need to pick cancer early if you have it. Early. We want stage 1, at best stage 2. By the time we are talking stage 3, most of the treatment we are going to recommend will
What is stage 3, Doc? What is stage 3? I think we spoke about it maybe in the
yes, I'll summarize it very simplistically.
Yes, please summarize for us. Yes.
So let's say when you've got stage 1, think of let's take an apple and then you can cut it into half. So stage 1 is the half of the apple, one half of that, so a quarter of an apple. The cancer is confined somewhere there. So if you took an apple, you go through the center and then you cut it into quarters. You've got 4 quarters now. If we've got cancer only in a quarter and it's not outside the peel or the skin, that is very early cancer. Sometimes it's so tiny, it's a few millimeters, we can measure the size. Once it's involving 2 lobes, meaning one half, we are moving to stage 3. If it passes to both halves, or maybe even outside the prostate itself, or now it's going to the glands, now we are talking stage 3. Stage 4 means that it's all over the body. It's everywhere you can think.
Okay.
It could be in the lungs, the heart, the brain. So now, the treatment side effects are permanent, unfortunately, because you need more aggressive treatment regime to kill these rather advanced aggressive diseases. Meaning the chemotherapy, the external beam radiation, where we radiate everything from outside, as opposed
so
to
we're burning stuff. We're burning.
Yeah, we burn everything from outside. Think of you taking a torch and shining it into somebody's whole face, as opposed to putting little in their mouth and then put them in, let them feel it from inside. Simplistically put. So radiation means that's what it's going to do. It bends the nerves, and then the chemotherapy also disturbs the hormones, disturbs the testicles, and in particular with prostate cancer. It's one of those cancers that are hormone dependent, like breast, meaning that it grows from our own chemicals. Testosterone, which comes from our testicles, it's food for prostate cancer. So if it's advanced, we have to cut down that testosterone. That is castration, either chemically or we do it either surgically. Those instances, we won't be able to salvage them easily, except with invasive procedures like what we call penile surgery, where we might even need to put a prosthesis. Just like people put a prosthesis on their leg, there's a prosthesis for a penis. It's a long discussion. It's got its pros and cons, but that's probably what's available for you. Second to that, in some men, they could be able to use something called a vacuum pump. Now, this is a cylinder which sucks blood into the penis and causes it to erect. You then have to apply a small band so that the blood doesn't escape at the bottom part of the penis where it is coming in contact with the testicles. And then because now it is engorged, you are able to have penetrative sex. Those tend to be the only maybe viable options that if you require penetrative sex. Otherwise, you have to sit with sexology for non-penetrative intimacy, because that option still remains. It's not easy for people to deal with, but there is non-penetrative intimacy, the spouse and everything involved for you guys to realize what could be done and what could be offered. Early on, when it's stage 1 and stage 2, we do treatment that are still for cure, but also that preserve functioning to as much as it's humanly possible. And if it's surgery, it will include something called nerve sparing. And then after that, penile rehabilitation. If it's radiation, we will recommend something called brachytherapy, where we put seeds of radiation inside the prostate to burn it from inside, as opposed to burn everything from outside completely. And the reason for that is because going back to our prostate as a narki or nectarine, if you're holding it in your hand, at 5 o'clock, that's where the nerves are, and at 7 o'clock, that's where the nerves are, and they envelope the skin of this prostate outside, and they run like ropes and turn medially inside where the prostate, where the nectarine will be caving, and then join the penis as a stick. So there is no way to avoid working around those nerves. The only question is that how many of them can we save? That is influenced by the disease and by the degree of presentation. Very, very important. And then once that is done, lastly, to just summarize the available regime, things like Viagra, because it's easy to call it that so people can know what we're talking about. Viagra, Cialis, and other related substances, and injections to the penises called Coverject, Bimix, Trimix, the type of injections we get from men's clinic. And then, of course, there are herbs which people attest by. We from the medical profession, myself, Dr. Mdlalose, our colleagues, Dr. Nolu, we're not necessarily able to sit there and say, go use Moringa. The health profession can look at us and say, are you a herbalist or are you a medical profession? But people will tell you, I use Moringa and it works. And if you bought it from a reputable pharmacy or a reputable retail or health shop where you can look what is inside and we know it's not going to kill you, it's really your decision if you want to use it. I'm not able to tell you how it's going to work and if it's going to work, because I'll keep telling you I'm not a herbalist. I will go to what is registered properly that I'm allowed to prescribe. So within that limitations, we will then be giving you injections or else the Viagra and related substances. And in some instances, if now you are cancer-free for 2 years, we also will test your testosterone levels. And if it remains low, we can give you testosterone supplements. So this now is a very involved regime, and it's always helpful if you come with the partner. Please come with the spouse. Men wants to hide that they have to use injections, or they have to hide that they have to take tablets. And now you're already stressed. Meanwhile, after taking these tablets, you need sexual stimulation. Now you can't have sexual stimulation because you are hiding it from your spouse. So it's very, very important that once you come for those, go to your general practitioner or with your sexologist, or even with a psychologist, with your spouse, so that you can be taken through all the pros and cons and the nitty-gritties.
But I think that's the importance of bringing Abomama to these conversations, because, you know, if Ekhaya Ubaba is under a lot of pressure to perform, they will hide things because, you know, there is that stress. Whereas when Umama understands, like you're saying, the conversations are more, you know, it's more inclusive in terms of just the discussion. So maybe to recap, you said when it's still spread too much in the body, you can still spare the nerves, because the nerves are important for the sensation, for also just to have a healthy erection. That's what you said. But when it has spread everywhere else, even the type of surgery that you do, it destroys the nerves, which is why for most of the people who have had those very extensive surgeries, so the operations are such that they may not necessarily be able to regain those erections, and therefore you may need those much more complex solutions that need to be discussed with the clinicians. But for some of the people who have had early cancer, where it has been treated, where the nerves have been spared, there are additional things that can be used to help. So you spoke about the Viagras and similar treatments. You spoke about measuring and testing for testosterone to see if maybe that you can still boost, but those are the different treatments, and also it depends on the extent of the disease and also the treatment that has been used. Did I summarize well? Okay.
Absolutely.
Then,
Just to add, also injections on the penis called
and the injections.
bimix, trimix. Yeah.
Yes. So there are various other treatments that you can get, but it also depends on the extent of the treatment that you have received, which will then guide the doctor in terms of what they need to do for you. And then I think you spoke beautifully about the conversation between the doctors and Abu Mama, so that it becomes a couple's decision, and also, not pressure from Ubaba. If Ubaba has had the treatment and they are unable then to have an erection, Mama needs to understand, and then they can have a discussion around how they will still be intimate, but maybe not the same way that they used to be in the past. So I think that covers it. And then there's been an issue, in fact, that has been raised, because I've got two other things that I want us to cover before we close up. We've got 4 minutes. Does abstinence increase the risk of prostate cancer? In 2 seconds. If you don't have sex,
the scientific answer is no. It's a theory. Okay. It's a long theory, and the long theory goes like, if we don't ejaculate, there is a risk of congestion, and with congestion, a risk of inflammation. Now, with inflammation, blood supply comes, there is growth of everything around, and if you had indolent cancer, that cancer will grow. That's the theory. So we haven't really proven this beyond reasonable doubts. The level of evidence is what we call expert witness, and they will tell you if you ejaculate 21 times in a month, that's going to limit prostate cancer. It is a hypothesis. It's a theory.
Okay, so people must not feel bad, because now people are feeling I'm not having enough and therefore I'm at risk. So at least we've touched on that. Dr. Mhlalose, herbal medicines, the role of herbal medicines.
Thank you for asking.
So Imbiza and all of those things, please, in 2 seconds, please help us here. What is the role of Imbiza?
Thank you, Dr. Nultan. As doctors, we are scientists, so we depend on research, evidence-based information. So most of these Imbizas, herbal medication have not been tested. So as medical doctors, we try by all means to shy away from them. We stick to what we know, what we have studied, what we have seen working on patients, on trials. So in a nutshell, Imbiza is a no from our side.
Absolutely.
So I think this webinar is incredibly informative. So thank you so much, doctors. We've covered a lot of significant ground beyond alcohol and sugar diabetes. Could we delve into the potential interplay between socioeconomic factors and prostate cancer risk, exploring how access to healthcare, diet and lifestyle choices, and environmental exposures might collectively influence the disease's progression or prevalence. So if we have one answer in 1 minute to say, is socioeconomic and environmental factors influencing the prevalence and progression of prostate disease?
Yes, it does. Yes, yes, it does. Studies were done in the developed countries. We've got positive data from ourselves in the African continent. But what we have seen is that access to healthcare facilities, when you need to be screened earlier, the type and the quality of what we ingest. So, for example, amongst the Black Americans who are a lot on fast food and everything like that, they were found to have increased body mass index, so they were obese. They had higher risk aggressive prostate cancer. We are seeing similar pattern even amongst Black African men who are not necessarily in the US. We also know that a Mediterranean type of diet where there is lots of good oils, lots of vegetables, etc., fish-based products like they do in the Far East are much more healthier than eating chisanyama every day. We know that processed meat, and I said every day to make sure that you can still eat it, it doesn't have to be our staple. We know that if you move away from processed foods, processed meat in particular, not only are you limiting the risk of prostate cancer, but you're also limiting the risk of colon cancers. It does not mean that red meat, as it said, totally, it's a big no, it is going to cause prostate cancer. Not necessarily. There are people who go on what they will call a carnivore diet, and they still do well on that. It's a lengthy topic for many, for different days. But the most important part is that you must have access to adequate health professionals and health centers that are able to perform basic screenings, basic tests, and general life health screening, healthy eating, no smoking, maintaining good body mass indexes. Those things are influenced by our socioeconomic status a lot. So yes, it does.
1 second, we are out of time completely. Is being uncircumcised a problem?
No.
Not at all.
Okay.
It's a choice.
It's a choice. Thank you so much. Okay, I can see here that there will be another session that we will have to have on testicular cancer, testicular health, because I hear people speaking about twisted testicles and all of that. Unfortunately, we're not covering it today, but it's a topic of another day. But maybe just in summary then to say healthy diet, good physical activity. We speak about at least exercising 30 minutes a day for 5 days, or at least 50 minutes times 3 days, at least to get a good physical activity. We must manage the weight. We must not drink alcohol, especially excessively. And then smoking is also a problem. So I think we've covered most of what we needed to cover today. I mean, we can have the full day of just discussing men's health, but I think today we decided to focus on prostate health. And I'm hoping that, you know, with this information, it allows people to engage with their doctors, because remember, we're just providing information, but at the end of the day, the discussions need to happen with the doctors. So I have to close it right there, doctors. And thank you so much once again. I'm sure we'll have another day where we continue with, with this discussion, maybe covering other topics. I've seen some ladies also asking questions here. We will have a dedicated female session where we'll cover some of the questions that have been raised. But absolutely, all that is left for me is to thank our Uma Bishop and Bishop for allowing us this opportunity. Honestly, this platform is an amazing platform to share information. And thank you so much to people who have posed questions. Thank you, Dr. Nhlanhla Mdlalose and Dr. Kaboyijane, for sharing so freely and really for taking the time to be here with us this evening. We just want to thank our Almighty for guiding us, for the wisdom, for everything that He continued to enable us to do. And with that, I just want to say thank you and have a good evening, and to God be all the glory. Thank you.
Amen.
Thank you and goodbye.
For having me. Till next time.
Thank you. Next time. Thank you.
Next time indeed.